is Jacqueline Garcia, and I'm from Dana-Farber Cancer Institute. At the AAMDS meeting in 2022, Dr. Borate from Ohio State and I got to participate and co-chair the treatments for MDS and secondary AML session on May 20th. We had a 9-speaker panel, and it was an incredible session, very interactive, and it highlighted many of the major updates from ongoing clinical trials in the effort to try to improve our MDS care. In a few of the sessions, we wanted to recap the highlights of the many panel discussions that were underway and the presentations that were provided. From our colleague in Hamburg, Dr. Nico Gagelman presented an update on how we should consider transplant for patients with MDS or those with subsequent secondary AML. He highlighted the challenges of patients that are often pre-treated with hypomethylating agents and their ultimate outcomes by reviewing the data from Dr. Kroger with Vidasa followed by transplantation. He also brought up prognostication that ought to be considered, including incorporation of genetic mutations when making a decision for bone marrow transplantation. He highlighted a lot of the areas that are still underway, especially because we do consider transplant a first-line option for patients with high-risk MDS, but we still have huge ways to go to prevent disease relapse post-transplant. In a subsequent session, Dr. Brittany Reagan presented a really comprehensive follow-up on what we're doing with our patients with lower risk MDS. She highlighted a patient case for someone who is transfusion dependent and all the challenges that come into play for patients that have symptomatic anemia, and highlighting the luspatercept, which is a drug approved for lower risk MDS and featuring ring sideroblasts, which serves as an erythropoiesis stimulating agent, highlighting many of the unmet needs we see in MDS, from transfusion dependence to low blood counts to symptomatic fatigue. She presented through a tour de force effort, all the phase 1 through 3 trials and their ongoing efforts with trying to improve transfusion independence. So in her presentation, we really heard a lot about the holes in the field with where we can serve to improve lower risk MDS for our patients. In the higher risk MDS talk presented by Dr. Borate, she also presented very challenging cases of patients and the new treatment options that are available, given that there are many ongoing studies that are presenting more options than ever before for our patients with high risk MDS. But ultimately, there remains a lot of challenges given how given the age of patients and the concomitant comorbidities. She brought up a lot of the highlights of the phase 3 ongoing trials that we need to look forward to, which we hope will replace the current standard of care, which is hypomethylating agent alone, highlighting the combinations with venetoclax, sabatolimab, and magrolimab therapy. And she brings up the genetic mutations as something we ought to consider when thinking about different subsets and how they might benefit from these new novel agents. I had the opportunity to present data with venetoclax and azacitidine. We have learned from the approved AML therapy that there is a significant amount of clinical activity and safety in high-risk MDS patients and frontline and in the relapse setting. We have an ongoing phase 1 study that has demonstrated a high response rate and an improved survival benefit, although this was not a randomized trial. And we highlight the fact that there's an ongoing phase 3 study called Verona that is comparing azacitidine plus venetoclax versus azacitidine plus placebo. We truly hope that this is one of the phase 3 studies that we all look forward to see how it may help to impact patients, as there looks to be broad activity overall, regardless of what genetic or cytogenetic subset the patient comes from. And Dr. Andy Brunner also presented the sabatolimab data, which is a TIM3 monoclonal antibody in conjunction with patients with MDS or AML, highlighting that there is safety across the board, despite this being an immunotherapy, showing feasibility of drug administration, not a lot of hematologic toxicity, and the broad effects that are seen across the different genetic subsets, and an early sign that there might even be some increased responses among those with P53 mutation. The long-term follow-up is needed. There is an ongoing randomized trial, which we hope to see data that supports its use for patients broadly with higher risk MDS. I'll pass to you, Dr. Borate, Dr. Salmon's talk, and thereon from the session to try to pull up some highlights.
Thank you, Dr. Garcia. I totally agree with you. As you mentioned earlier, this was a wonderful session and really highlighted the progress that's been done in myelodysplastic syndrome therapy for high-risk disease with clinical trials. So continuing on, Dr. Salmon presented data with an antibody called magrolimab. This is an anti-CD47 directed therapy. Some can also describe it as immunotherapy. And the idea is that this antibody targets what we call a don't eat me signal, which really prevents our own immune system from attacking these cancer cells or these MDS cells. And the idea is to combine this immunotherapy with magrolimab along with hypomethylating agents, which have been approved for MDS therapy for a long time. He gave us an overview of the data in the clinical trials so far, showing a lot of promise with very high response rates with this combination. He also discussed some of the expected side effects or toxicities we can expect with this treatment, which were currently illustrated when the FDA took another look at the ongoing clinical trials. And then determined that they were still safe to continue with this combination. So we're really looking forward to the data on the phase 3 randomized clinical trial, looking at this combination with this anti-CD47 antibody magrolimab, known as ENHANCE. And I think this will be another exciting possible option for our patients. He also highlighted the fact that patients that have the worst prognosis and have a mutation in a gene called TP53 seem to have a disproportionate benefit with this combination. So again, this is data that we're eager to see as these clinical trials continue to enroll. We then had a discussion with Dr. Anand Patel, who talked about targeted therapy for MDS. As many of you may know, there are very similar mutations in myelodysplastic syndrome that we see in acute myeloid leukemia or AML as well. And in AML, we have several what we call targeted therapies. These are drugs that target very specific genetic mutations seen in patients with AML. And we're hoping we can leverage that information and target the same mutations seen in MDS with the same agents that we know are effective and safe in AML. So he presented some exciting data on clinical trials being conducted in Europe and hopefully in the United States as well, that show promise with these targeted agents. So I think that was another thing that we're looking forward to, because it would be nice to use more drugs that are targeted and have less toxicities in our MDS population. And then last but definitely not the least, we had a couple of other speakers. One was Dr. Zaidan, who again talked about a very challenging scenario where patients with MDS have received hypomethylating agents like azacitidine and decitabine and then have stopped responding to these agents. And he talked about what other options could be used in patients that have stopped response. He highlighted the fact that you really don't want to change from one agent to another. So you don't want to take one hypomethylating agent. If the patient has lost response, just change them to another. We really need additional therapies. He talked about the promise of adding the therapy that Dr. Garcia discussed, the pill known as venetoclax, to these hypomethylating agents, and the clinical trial that showed benefit with that as well. And then the last speaker, Dr. Garcia really talked again about something that we think is an exciting option for patients, where instead of coming, every day for 5 days or 7 days to get an injection or an IV infusion with these hypomethylating agents, you can actually now take an oral medication or a pill that has the same agent and that has the same sort of availability in a patient's body. And he talked about the studies and the data with these oral agents and how we can leverage that in the future to maybe do these combinations where the patient can take a lot of the therapy at home instead of coming to our infusion centers every day for a week. So all in all, I think this was a really exciting session. We hope you get a chance to see some of these highlights, and please, you can feel free to contact any of us if you have any questions.
Really wanted to add to that those beautiful comments that what we got to hear about and discuss among each other and with the group that was present is that we have phenomenal clinical studies that are currently underway, and we really need these trials and participation to occur so we could change standard of care. I don't think that these treatment options on the clinical trials are last resorts. I think they are very clearly showing promise and could replace frontline therapy. So I encourage people to consider participation. I know that we have both personally enjoyed seeing how phenomenal patients can do when they're not just getting standard of care. And in the context of the clinical trials, I think we're offering studies that look to be safe based on how the protocols are written. And that's why these trials need to happen, so we can confirm that that's true. And we're starting to see some improved efficacy. So it's really giving us hope that we can change the outcomes, the bringing the transplantation rate, the long-term survival. And lastly, as Dr. Borate indicated, we are starting to get more therapies that might become easier for our older patients, which represent the majority of patients with MDS. So we look forward to learning about clinical trial regimens that could be given closer to home, or even in oral formulation, or demonstration that there's safety so that our most vulnerable population can get very effective therapies.
Thank you for that really important point, Dr. Garcia. Again, to highlight, please do not consider clinical trials as a last resort. As we just discussed, most, if not all of these clinical trials we talk about are what we call frontline, meaning right after you have a diagnosis of myelodysplastic syndrome, so that we can improve outcomes. We haven't had a new therapy in over a decade now, and we really want to change that for our patients. So thank you again for listening, and please let us know if you have any questions.